What is the first thing you picture when you hear the word fall? Changing leaves? Football? Pumpkin pie, perhaps? Ah, fall. What a pleasant word. For those involved in healthcare, oftentimes the word fall brings different pictures to mind. We all have them. For the majority of us, a stumble, trip, or fall is no big deal. For those on the younger end of the spectrum, who are fit and healthy with no debilitating impairments, a fall is sometimes even humorous. Picture a baby learning to walk for the first time. Falls are expected and often even encouraged as part of the trial and error process. But for those who are part of the geriatric population, commonly considered to be around 65 years of age and older, falls can be very serious and have major consequences. Picture an elderly person falling instead of a baby. Not a very pleasant picture, is it? From a medical perspective, falls are not to be taken lightly. They're an all too common, preventable side effect of aging with high prevalence in the elderly population. We know that on a biological level, aging results from the impact of the accumulation of molecular and cellular damage throughout life that leads to a gradual overall decrease in our physical and mental capacities, which ultimately puts us at increased risk for disease and death. It's easy to view all older people as frail and breakable, but that's simply not the case. It's important to note that age-related changes are loosely associated with a person's age in years. Some people age phenomenally well, like Chuck Norris, who's 76, or Sylvester Stallone, who's 74. Never would have guessed it, would you? Others, in the same age range, are very frail and have significant health issues. Regardless of how well or how poorly people age, falls still have a high prevalence in this population. The many common negative side effects of aging and comorbidities present in elderly individuals such as obesity, diabetes, osteoporosis, thinning skin, decreased muscle mass, and slower reaction time have a huge impact on health outcomes and quality of life. The reality is that as we age, we lose that interesting rubber ability that babies have to stumble, bounce, and recover easily from a fall. We begin to become more and more susceptible to injury due to these bodily changes, so a fall is no longer a cute oopsie, it's a potentially devastating event that can severely negatively impact quality of life or even be lethal. Each year, approximately 30% or 1 in 3 adults over the age of 65 fall, resulting in $30 billion in medical costs. To put this in perspective, we spend only about $5 billion on cancer research every year. 20% or 1 in 5 of these falls result in serious injury. Regardless of injury, a fall may result in a fear of falling that further limits mobility and contributes to functional decline. In addition, approximately 2 to 3% of hospitalized patients fall each year, about 1 million falls total, with almost a quarter of these resulting in injury and costing patients and third-party payers nearly $14,000 more per hospitalization than for those who never fell at all. These numbers should shock us, and unfortunately, they have risen dramatically in the last decade and are projected to continue to skyrocket as the baby boomer generation ages. What can we do about this? We have a moral obligation to the geriatric population to be serious about fall prevention. Unfortunately, the multifactorial etiology of falls is very complex, thus requiring an interdisciplinary team along the healthcare continuum to attempt to preclude as many as possible. Fortunately, physical therapists are well equipped with the skills to prevent falls. They can use screening tools and risk factor remediation strategies in combination with their clinical decision-making skills and the wealth of evidence-based knowledge available to play a key role in this team. The American Physical Therapy Association has published a clinical practice statement, which are recommendations based on multiple clinical practice guidelines on fall management for use by physical therapists. There are 3 main domains that the APTA identifies: screening, assessment, and interventions. First, screening. PTs should routinely ask their older patients if they have fallen in the previous year, including not only a history of falls, but also the context of those falls, as well as asking their patients if they perceive themselves having difficulty with balance or walking. If a patient reports any falls or reports difficulty with balance or walking, PTs should screen further by doing a gait and balance impairment assessment. If the patient has fallen more than once in the last year, or if a patient reports 1 fall and has an observable gait or balance impairment, a multifactorial and interdisciplinary risk assessment is indicated. If needed, this assessment should be individualized to the patient and should include medication review, medical history, including new and unmanaged risk factors, and ICF model related items, such as strength, balance, gait, ADLs, footwear, environmental hazards, cognition, neurological and cardiac functioning, vision, and incontinence issues. The PT should then refer out to other medical professionals as needed to glean as complete of a picture of their patient as possible. The full assessment should lead to creation of individualized interventions that address all of the patient's risk factors, including strength, balance, and gait training, as well as home and footwear modifications and other ADL training. If we look at the figure, we can see that as an older person encounters a physical therapist, the PT should ask the person whether or not they have fallen in the previous 12 months or if they have difficulty with balance or walking. If the answer to this question is no, then the initial screening is negative and the physical therapist can continue with usual care. However, if the PT observes balance or mobility impairments, or if the individual says that they have fallen in the last 12 months, the PT should conduct a balance and mobility screening. If no impairments are identified, then we can continue on with our usual care. However, if balance or mobility impairments are noted, we must then conduct a multifactorial fall risk assessment. If there are any risks that are outside the scope of the physical therapy practice that are identified, we should refer to the appropriate healthcare provider for the identified risks that are outside of our scope. However, all of the risks that exist within the scope of our practice that are identified should be remediated by the physical therapist. In conclusion, physical therapists have a key role to play in fall prevention. Falls tend to increase in frequency and severity as we age, causing financial strain and decreased quality of life, both on an individual and societal level. Luckily, years of research and the development of a clinical practice statement from the APTA have paved the way for physical therapists to use screening, assessment, and interventions to decrease the number of falls in the geriatric population.